So the types of clinics that I do in Bristol are predominantly kind of rhythm management and inherited cardiac conditions. So syncope is one of the common things that gets referred to my clinics, and it's quite a common presentation in general in paediatrics. So I thought I'd just talk today about kind of what typical types of syncope that we see, and then kind of worrying red flags, and then I've just got a couple of case studies at the end for children that have presented to us with syncope. So syncope is really quite common. There's generally two peaks. It kind of peaks in the younger ages, and that's usually due to kind of breath holding and reflex anoxia. And then there's a second, slightly larger peak of syncopal presentations, and that's normally in adolescence. Most types of syncope in pediatrics are benign, but there can be some children that will present with slightly more atypical or worrying features. And those are the kind of ones that we'd probably say should come straight to paediatric cardiology. So there are paediatric clinics as well that will see kind of fits and faints. I know that Swindon has one of these clinics, but sometimes I think if children have a really worrying etiology or if they have an abnormal ECG, those are the ones that we're very happy to see first, because these are the kids that we like to do kind of a rapid review and potentially start treatment rather than them seeing kind of multiple people. So in terms of definition, so this is one of the heart rhythm definitions from 2015. So it's a transient loss of consciousness associated with an inability to maintain postural tone. You get a rapid and spontaneous recovery, and then there has to be absence of clinical features which would be specific for another form of transient loss of consciousness, so that would differentiate it from an epileptic seizure, for example. When you look into the causes of syncope, there's some debate on this, but essentially there is a global kind of cerebral hypoperfusion that normally causes the loss of consciousness, but it can be secondary to lots of different types of etiology. It is really common. We quite often see a family history. So even in children where the etiology just is vasovagal, there's frequently a family history. If you start asking mum if she also fainted, they'll normally say, oh yes, I get dizzy when I stand up and I used to faint as a teenager. And so it is something that does tend to actually kind of run in families. And I said before, there is a kind of a lower incidence, which is usually due to kind of the breath holding spells that we see in younger infancy. And then adolescence is really when we get lots of referrals for syncopal patients. So the common causes that we see, so some of these we wouldn't see in paediatric cardiology. So vasovagal, that's the most common cause of syncope, and that's a lot of what we see in cardiology. Breath holding patients, I think, are usually seen either presumably in primary care or general pediatrics. We sometimes get asked to see patients who have really significant breath holding events that result in kind of loss of consciousness and seizures, but in most cases these children have completely normal rhythm monitoring during the breath holding event. And then there's some etiologies which will be cardiac, which we'll talk through today. So I'm going to mainly focus on the electrical causes, and these long QT are a really important cause. Brugada is quite rare, but we do see it. We have had children that have presented who've just rested at home with a fever, and that's been their first presentation of Brugada. CPVT, obviously Wolff Parkinson White, if you have antegrade AF, can cause syncope, and then short QT is really rare. We have seen a child who had a collapse on a cadet camp recently because she had undiagnosed primary carnitine deficiency, which presents when you fasted with short QT. And she ended up on ECMO. She was a very interesting, she was a teenager. And she just kind of presented with, feeling unwell when she didn't eat very often, which is quite an insidious, lots of people won't feel very well if they're fasting, but that's how she presented. She had a very abnormal ECG. And then the structural causes, which I won't go into so much, but obviously children with hypertrophic cardiomyopathy, if they've got a coronary anomaly where they've got an anomalous coronary course that gets compressed when they're exercising because of dilatation of the pulmonary route, those can present with syncope, and we've seen patients that have presented with syncope running to the bus that have had abnormal coronaries, ARVC because you get exertional ventricular arrhythmias, and then aortic stenosis as well. And then there's obviously neurological and metabolic and psychiatric causes, which are normally, usually wouldn't come through us in pediatric cardiology, but it's always important, I think, to think about these patients. And sometimes we do end up seeing children where they're also under neurology, but perhaps things don't really fit. And so yesterday, I had a patient on my list to put a loop recorder in where she was having kind of out of body experience symptoms, which isn't really cardiac, but we know she also has long QT and she does a lot of dancing. So she was offered a loop recorder just to make sure that this absolutely wasn't anything cardiac. And, if it is, then we've diagnosed that. But if it isn't, then neurology have a slightly clearer idea in terms of their follow-up as well. So sometimes we'll end up seeing patients with the neurologists. So the key thing in a child that presents with syncope really is the history, because we're not expecting, and it's not really advised to do an ECG. If you look at the most recent Canadian Paediatric Cardiology guidelines, they felt the yield was pretty low if you ECG every child that comes in with syncope, and just to reserve that for the more worrying histories, but the history really is key. So the prodrome, which the child describes, is really important. If it's vasovagal, then the symptoms they may describe is feeling quite warm or hot, wanting to take off their coat or their jumper, feeling quite clammy. Some children may get a visual change, so you can get kind of spots or sparkles in front of your eyes or kind of tunneling. Some children may get auditory changes. When they looked at 154 children, I think this was a Canadian or a US study, with syncope, 85% had a prodrome. But interestingly, when they looked at those children that were known to have a cardiac condition, only 40% did. So it's not as specific as you would think. But we normally say if you don't have a prodrome and you just collapse with syncope, those are children that we'd want to see. So the circumstances around the event are really important, what they were doing at the time. So, for example, if they've just had blood taken, we had one child actually that kept fainting every time he saw a medical program on TV. So some children are really sensitive to the sight of blood or the thought of a medical procedure, and then can get classic vasovagal symptoms. There's something called the Calgary score, which has been used to try and differentiate patients that have a cardiac syncope from more kind of orthostatic kind of POTS or orthostatic hypotension, and that looks at the events around. And so if you've got a score of, I think, -3 or less, then it's more likely to be cardiac. And mid-exertion is a really kind of worrying sign for us. There's been quite a lot of studies looking at post-exertional syncope, and that's normally benign. So children can feel quite faint when we run them on a treadmill here, and that's been seen in adults as well. That's not normally as worrying, but if you've got a syncopal event whilst you're running, and we'll discuss a case study for that, that's obviously a real worry, and it would usually be abnormal. So on examination, obviously there are going to be things that are more concerning. So lots of children will have innocent murmurs that come and go. I think 80% of children will have a murmur at some point. So if it's a soft murmur, the child is maybe 11 or something and has been seen multiple times, and this is the first time you've heard a murmur, then it's probably something, or they've come in with a viral infection and have been feeling a bit faint, then it's probably innocent. But certainly if you've got a harsh murmur, if you've got abnormal pulses, clearly if they've got a stenotomy scar, then those are the children that you're going to be slightly more suspicious that there might be a cardiac etiology. In terms of irregular pulses, so most children that we see will have sinus arrhythmia, which is where your heart rate varies with inspiration and speeds up and then slows down. So a lot of the children that we examine will have irregular heart rates just with respiration. So I don't think that's a particularly specific sign for pediatrics. So the Canadian group argue that there's a pretty low yield with ECGs if you perform them routinely, but if there's anything worrying, so you really don't think this fits with vasovagal syncope, if it's mid-exertion, so if they were swimming and looked unwell and had to be pulled out, that's obviously a worry. If they're in the middle of running and they suddenly have a syncopal, loud auditory noise or sudden emotional stress is a worry because of long QT or CPVT. And then if there's a worrying family history, for example, so if there is a sibling of that child that's passed suddenly, or there's a first degree relative, or somebody in the family has drowned or passed in their sleep unexpectedly. These are the kind of things that we try and ask about in clinic. Or if there's an unusual history of seizures in the family but not a clear diagnosis of epilepsy, then that's another kind of worry for us. Or if a child's been started on a new medication and then had a faint, because we worry about that with long QT and Brugada, because those medications can trigger arrhythmias in patients with kind of primary electrical disorders. We don't do the tilt test really anymore. You can get most people to faint if you put them on a tilt table, so it's not hugely specific and it's quite unpleasant for the child. So we don't perform it here. When I worked in Canada, we didn't do tilt tests on anybody there either. So it's not usually indicated. And just the thing about the history as well, in terms of, the history doesn't really fit. So I saw a child who, in my pacemaker clinic a couple of weeks ago, who had a history that sounded very much like, vasovagal syncope. She'd had quite a prolonged pause, which sometimes we see in patients that have kind of reflex anoxic syncope. And so she'd had a pacemaker in because the pause was 30 seconds, so it was quite significant, but she'd never really needed pacing and she was improving. And a lot of her symptoms were on standing up and feeling dizzy, which is quite reassuring. And so I was starting to think about whether she actually really needed her pacemaker. And then her mother was mentioning events which really didn't sound suggestive of vasovagal, such as, she'll just be walking along and she's walking to school and then suddenly, or she's walking in between the classrooms at school and she suddenly feels very faint and kind of doesn't have a true syncope but kind of falls to the floor. I was thinking, well, this doesn't really fit actually. And then when we did her pacing check, we found that she was having episodes of complete heart block when we just stood and kind of watched her pacing. So I think that was a really interesting one, because if you'd stop the conversation at just, oh, I feel a bit dizzy when I stand up, then that would lead you down a path of, well, this is probably just kind of some teenage dysautonomia and you're not drinking well enough. But actually, the other parts of the history were much more suggestive of pathology. And actually, she's a patient that will now keep the pacemaker in. So I think the history really is important to try and get to the bottom of it. So in terms of kind of concerning features, obviously we've talked about whether you've got a suspicion of structural heart disease, whether you've got an abnormal ECG, pathological murmurs, whether they're a known cardiac patients who are fainting, that obviously syncope is common. So some of our cardiac patients will just have vasovagal syncope, but we're always going to be a bit more suspicious of these patients. So those would be important ones to run by us and make sure that we're happy with. And so looking at kind of types of syncope, so vasovagal obviously is one of the more common and usually very benign. So it usually occurs if you've got an upright posture which has been held for more than 30 seconds. If you've had a painful procedure, or if you're in a medical setting, then some children will be more likely to faint, or I had a child recently that fainted because someone next to her in a medical bay vomited. So those are the kind of things that fit more with vasovagal, and they often get a prodrome of feeling quite sweaty and quite warm and nauseous and can look a little bit pale. It is associated with hypotension and bradycardia, but you'll often only see the bradycardia if you've got a loop recorder or a Holter monitor on at the time, and then children can be quite fatigued after them. In terms of the pathophysiology, there is still a bit of debate about this, but essentially the thought process is that, when you normally rise upwards, then, you normally have activation of your sympathetic nervous system, which causes vasoconstriction, and your blood goes where it's supposed to go. But often, and we see this lots in children, where they have kind of they're sitting for long periods of time in classes, or they're sitting for a long time watching TV, and they just get kind of pooling in their venous system in their calves, and they just stand up, and then they don't get that sudden kind of vasoconstriction. And what that happens is you then get secondary decrease in cardiac output. So you get kind of empty heart syndrome, where your left ventricle is kind of more contractile to try and account for that low cardiac output, and then that in turn triggers a vagal response, and then children can become quite profoundly bradycardic with that. So part of it is the hypotension from sudden decrease in cardiac output, And then part of that is that kind of paradoxical vagal response, where they'll also become bradycardic, and that's where we say it's a cardioinhibitory type of syncope. And we see that really common in adolescents and in children that have kind of dysautonomia, where they've done, maybe a big growth spurt and their autonomic nervous system just hasn't matured. And so and when you add on to that they're, sitting for long periods of time in class, and then they suddenly have to get up quickly to move classrooms, their sympathetic nervous system just hasn't kind of just isn't quick enough. And in some children you can also get paradoxical vasodilation, which doesn't help. And so in children with dysautonomia, they really struggle with sudden postural changes and get usually not often syncope, but often pre-syncope that can be quite debilitating for these patients. Other causes of syncope that we see in young patients, so reflex anoxic. So it's usually young children. They often have a distressing stimulus, such as kind of bumping their arm or falling on the bottom, and then they'll get a kind of loss of consciousness, and some of them will then stiffen and have a more of a seizure type pattern. So it can be very worrying for the parents because they're worried their child has had a seizure, but there's normally a clear history of them being having a painful procedure performed, and they usually grow out of this. But sometimes we see it in children where it's a little bit where they're kind of in their primary school years and they're still having these events, but it's normally younger when they're very upset because they've just bumped themselves. And in breath holding spells, again, so most of these children wouldn't come to paediatric cardiology, but it's seen quite commonly in healthy children. And it's usually children are very upset, and then they take a sudden deep breath in, they go quite blue, and they have a big apneic episode and look quite cyanotic. It's not really behavioral, and it's an involuntary reflex, but it can be quite prolonged in patients, and also again very stressful. There have been a couple of papers, I think in Turkey, which have looked at whether iron supplements work. I think they've shown that there was a children with profound breath holding events were more likely to be anemic. And I think there've also been studies looking at theophylline. So we certainly had a child in Canada where they had quite profound breath holding and would then go on to have seizures, completely normal cardiac monitoring. And so that patient was started on iron supplements to see whether that made a difference. I'm not sure there's huge evidence for that, but certainly there have been some case series that have shown iron supplementation may be beneficial in these patients. And then I was just going to talk through the kind of cardiac causes for syncope. So the ones that we worry about, what to look for, how to kind of tease them apart, and then talk about a few patients that we've seen in our clinic that have been referred from syncopal events. So in terms of a kind of arrhythmogenic events that can cause syncope, long QT obviously is one of the big ones that we worry about, because patients with this can just present with an arrest, and that could be the proband in the family can just be someone that's had a sudden event, either exercising, or sometimes if it's long QT type 3, they may have passed in their sleep. So it's genetic. It can be de novo in a child, or it can be inherited. It's usually autosomal dominant, so there'd normally be a family history of some funny event in either mum or dad as well, or a sibling. It's a primary arrhythmogenic disorder. Some rarer types, such as Anderson-Towel, are also associated with a skeletal phenotype, but most of them, children have normal growth and development, and they're just predisposed to having runs of ventricular arrhythmias. And the key thing here is the history with these patients. So there's a strong kind of genotype phenotype correlation. So most children with long QT will either have long QT 1, 2, or 3, and then there's much rarer subsets that make up the other kind of 20%. But in long QT1, there's a strong adrenergic trigger. So it's we always advise these children not to go suddenly diving into cold water, and any exercise that they do should be supervised. And most of these children would be allowed to take part in recreational activity, but not at a competitive or highly exertional level, because that tends to be the trigger. So they might have a history of, swimming and suddenly looking very unwell and having to be pulled from the pool, or they might have a family history of someone who's dived into a pool and then, been unresponsive, or they might have had a fainting episode whilst, running in a So we had a child recently actually that was in one of the big soft plays, and she started at the top of the slide. It was about 3 or 4. She's looked after by one of my colleagues, and she went down the slide, and by the time she'd got to the bottom of the slide, she was unconscious. And she was long QT. So it's that kind of excitement and adrenaline, and that was just a slide in a soft play. Or maybe they've gone pale and unresponsive on a roller coaster ride. So it's that kind of surge of adrenaline, and then the syncope that worries us in terms of looking for and wanting to rule out long QT. And then long QT type 2, the stimulus is alarm clocks and very loud auditory noises. And it's not so much that children are high risk, it's actually women, usually in the postpartum period. So they're a particular high risk group at that point. Children, and particularly boys, are high risk in childhood in long QT type 1. And long QT type 3, the trigger is often sleep. And so these patients are started on beta blockers. So again, it's that history thing about what the trigger was. So if a patient presented into GP or into ED with that kind of history, one of the first things we'll be doing is an ECG. About 30% of patients with long QT will have a normal ECG. And so that can be really difficult. And that's why if we've got a strong suspicion just based on the history, then we wouldn't discount them just after one ECG. If the history is significant enough, we'd actually do exercise tests as well, because that's one of the ways that we try and tease out whether they've got an abnormal QT response to exercise. The important thing with long QT on ECGs is that usually the ECG machine will overestimate. It takes an amalgamation of all the leads, and we know that the QT interval isn't as accurate. So, for example, we never use the right precordial leads in children. The T waves are very transitional, so we'd never use those to measure the QT interval. We'd always use kind of V5, V6 or lead 2. So, but when the ECG is reading it, it'll kind of amalgamate everything similar to a Holter. So it's not usually accurate. It's best to measure it yourself. And the other thing is it will include kind of U waves and things which we don't. So the recommended method in most international papers now is to use the tangent method. So you basically find the steepest slope of the T wave, and it's where it interjects with the baseline. You don't include the U wave unless the U wave makes up over 50% of the T wave, which it wouldn't normally do in pediatrics. That would be abnormal. And then this is the calculation. So this is BASIT, so it'll correct it for the heart rate in children. But there's lots of websites where like MedCalc, where you can put in just the number of squares, and it will calculate it for you, and it will do it for the heart rate. But most people use BASITs. There's Fredetia as well, but BASITs is the most common one, and the important thing is you just use the same one every time, because I think people can get into difficulty if they start using different methods. So, but the important thing is just to say that it will normally overestimate on the ECG. So the important thing is to look at it yourself and make sure you agree with the finding. Brugada syndrome is quite uncommon in children. I see it quite a lot in my clinic, just because the types of clinics I run, but it is rare. Again, like long QT, it's a primary arrhythmogenic disorder. It's thought to be inherited, but we only find a positive genotype in about 30% of patients, and it's a sodium channel disorder. And really, you can diagnose Brugada either because they'll present and they have an abnormal ECG. So lots of children I see in clinic will have had a father or a mother who will have gone into ED because they'll have had a faint at home, or they'll have been unwell with a fever. So somebody presented recently, a dad with a dental abscess, and he went into ED and he had this really abnormal ECG, which was diagnostic for for Brugada, where you've got this kind of raised ST segment, which is very coved, a bit like a kind of shark's fin, and then you get a T wave inversion afterwards. It has to be above 2 millimeters. And it's in the right precordial leads because, although we don't really know what causes Brugada, it's essentially the abnormal repolarization, of the right ventricular outflow tract. So it's normally the right precordial leads that we see this change in. And these patients, again, may have syncope either because they've got fever. So those patients who are gene positive may have a fever trigger, or they may have been on a medication, which is a sodium channel blocker, So all people with Brugada would be told not to take anything that's contraindicated in Brugada syndrome, classically a sodium channel blocker such as flecainide. So if you've had a patient that's recently been started on flecainide and then started having syncopal episodes, you would be concerned about Brugada syndrome. And it's not really exertional, the arrhythmias that they get. They often get them late into the evening, particularly if they've had a big carbohydrate heavy meal, is quite often when they present. Wolff Parkinson White. So we see lots of children with Wolff Parkinson White. Lots are asymptomatic, in which case we just say it's ventricular pre-excitation, but some will also have SVT. And we now, rather than, we used to risk stratify with kind of exercise tests and halters. There's a lot of data coming out now showing that actually exercising people doesn't necessarily risk stratify whether you've got a high risk or low risk pathway. So we do offer ablation to all children now because of the risk of having fast conducted AF, which conducts antegrade across the accessory pathway and can cause syncope. So if you have a patient that sees you where they've got a diagnosis of Wolff Parkinson White and they have a syncopal episode, those are children that we really want to see. And often, if it's a really suspicious history, we'll keep them in and we won't discharge them until we've done the ablation. Because children with Wolff Parkinson White, everyone is more likely to get AF as they get older, but patients with Wolff Parkinson White, just by themselves as a cohort, are more at risk of developing AF as well. And so that's the concern with them. Just SVT by itself doesn't normally cause syncope, but if you've got pre-excitation and you have syncope, then we do worry about that particular subtype of patients. And then complete heart block again. So lots of children will be picked up with this incidentally, but just be bradycardic. Or they might present with a viral prodrome and we'll realize that they've got complete heart block. So usually they present quite well and it's picked up incidentally. But some children could present quite late with kind of exertional symptoms, and they may have LV dysfunction and mitral valve regurgitation. And these are patients that we all offer a pacemaker to at some point in childhood, but we normally try and wait until either there's left ventricular dilatation or dysfunction, or the patients are symptomatic, because we try to reduce the amount of pacing that we perform in childhood as much as possible. So in terms of management, so most children that have syncope due to vasovagal don't need any acute treatment or management. The STARS website, I think, is excellent. It's got really good patient leaflets for fluid and salt intake and reassurance. Most adolescent children that have kind of symptoms of POTS or dysautonomia, where they get kind of pre-syncopal on standing or palpitations on standing, the key thing that we normally do, because it's the only thing that really has an evidence basis behind it, is an increase in dietary fluid and salt. And actually, I think this again was a Canadian study, but they looked at 166 children and they randomized them, and those that had oral rehydration salts showed a decreased recurrence in syncope compared to those that didn't. They're doing a study at the moment which is looking at counter pressure maneuvers to see whether that will make a difference, and they do advise that in patients have a clear history of vasovagal syncope, where one of the things is to kind of do this, or to kind of cross your legs, or kind of clench your buttocks, or kind of not jog up and down on the spot, but kind of work your calves up and down. And those are the kind of counter pressure maneuvers that they recommend to try and prevent syncopal events. So I think they're doing a study in Vancouver at the moment to look at that and see whether that's made a difference. But one of the first things we ask in clinic when we're seeing these patients is how much fluid they're taking. They're often not taking enough. And then salt as well. Do they have salt in their food? Do they have salty snacks? Some children don't like having salt in their fluid, in which case we suggest electrolyte tablets, although those can be really expensive. And I think sports drinks are expensive and sugary and often have caffeine in. So either electrolyte tablets or just adding, peanut butter into their diet, or some, salty cashew nuts or something. And the really key thing is increasing the fluid as well to try and help. And that's the thing that's been shown to be most beneficial in patients that have dysautonomia. So just to very quickly mention a couple of case studies. So this was a 14-year-old who was actually referred to Paediatric Cardiology with a suspicion of POTS. So she'd had pre-syncope on standing. But the key one was that she'd had syncope whilst running. So she was running from one friend to another in a field and had just lost consciousness and come round on the field. Her ECG, and again, this is really important because this is always pathological, had shown bidirectional ventricular ectopics. And I was called down to see her because she'd come in routinely to have a Holter, and the ECG was abnormal at baseline, and her Holter showed almost a 50% ventricular ectopy burden, which was significant. So the two things we're thinking about there is this CPVT because of the exertional syncope. And so we put her on a treadmill. At that point, her ectopy disappeared. So that's really kind of suggesting that this is probably Anderson-Towel, where you get a very high ventricular ectopy burden and you get a prolonged QT interval, but that's because you've got a very abnormal U wave that comes on at the end. And she's since had genetic testing, and she's on flecainide and nadolol, which is kind of standard therapy. She's had a good reduction of her ventricular ectopy burden down to 1% now. She hasn't had any further fainting episodes. She's got a loop recorder in, and her family are undergoing screening for Anderson-Towel. So that was a really interesting one because I think she was referred really as POTS, but it was the syncope whilst running, which is the key thing. This is a girl I saw when I worked in Canada who was 11-year-old and had basically arrested whilst standing on a diving board, and unfortunately had a very poor neurological outcome. But the interesting thing is, before she'd presented, is she'd had this history of having fainting episodes whilst in school plays, which again is that worrying because it's that stress, that kind of emotional stress trigger. And she had CPVT. And so again, you can see bidirectional ectopy and a very high ventricular ectopy burden that's usually triggered by emotional stress or exercise. So in summary, so syncope is really quite common, and it's teasing apart from the history, really, which of those we need to worry about. A lot of syncopal patients, I think, reassurance, the STARS website, making sure they're drinking enough and, have got enough salt in their diet. So a lot of patients we see in clinic will be able to be discharged with kind of reassurance. There is that subset that are more of a kind of severe dysautonomia. There is some overlap with chronic fatigue that end up being seen by general peds as well, where pre-syncope is a part of that, but not the full thing. And again, it's salt and electrolyte management with those patients as well. And the important ones to think about, I think, are just the red flags of which ones should really be referred straight to paediatric cardiology. And those are the ones where we're worrying about, is the long QT, is the CPVT. So it's kind of syncope on exertion. If you've got a trigger of an intense stress or emotion, if there's a sudden loud sound like an alarm clock or an alarm at school going off and they have a syncopal event, that's really worrying. They need to come in and see us. If there's a worrying family history and they've got syncope. And if you're concerned, do an ECG. We're always very happy to look over it. And I think the important thing with that is just to don't necessarily trust what the ECG is reading the QTC as. It's always important to double check that yourself. And if you think there's an electrical or a structural abnormality on the ECG, then that needs an urgent paediatric cardiology referral. And that's the end of my slides. Sorry, I was a bit fast.